Good morning, everybody. We'll just wait a few, not even a few minutes. We'll wait 30 seconds and we'll get started as people are coming into the webinar. I'll make a data-driven decision when we can start here. I'm watching the numbers rapidly accumulate. So we're up to 175. And it's slowing. So why don't we go ahead and start? Welcome, everybody. Thank you for waking up early if you're out on the West Coast and joining us if you're elsewhere. My name's Allan Levey, and I'm privileged to chair a great group of colleagues working with all of you in the centers to develop the UDSv4. We have a busy agenda today, so I'm just going to go to the next slide and just give a few minute overview to frame today's agenda and how that relates to the past. That's right, Hannah, if you could please advance the next slide. As we all know, the data that we are collectively putting into the uniform data set is just growing rapidly, and it's going to continue to increase in value and importance to the field. As you can see, we have well over 45,000 participants already in NACC with a large number of assessments. The neuropathology data continues to grow, the scientific impact continues to grow, and our Alzheimer's Disease Center network continues to grow, welcoming the new centers this past year. And so I think it's very clear the UDS is going to continue to have a big impact. If we go to the next slide. And we have to be mindful of that as we try to work together with NACC, with the NIA leadership. Appreciate Nina and their support, and everybody who's contributed to the clinical task force to thoughtfully go forward as we develop UDSv4. Today, we're going to give you a bit of a content update. But just to remind people, we have several challenges that are really significant. On one hand, we want to streamline and reduce the participant burden during the revisions to UDSv4. We clearly also have a growing need to keep up with science, technology, the changing world around us, whether it's COVID or clinical practices. The increased appreciation of the critical role of social determinants of health, all these factors mandate that we also continue to increase the scope of information we collect. So how to do that and do it in a streamlined fashion in a less burdensome manner remains a challenge for us. And so this whole process relies completely on all of your input. We really depend on it. Next slide. Just want to thank everybody who's been working hard to not just bring you these updates, but really almost weekly meetings for a lot of people. These are the leads of the different work groups, the technology work group, the clinical measures and diagnosis work group. Today, you're going to hear from a sub-work group as well, led by Dr. Howie Rosen and Dr. Kostas Lyketsos. You'll also hear from our cognitive work group leads, Andy and Lisa. And Lisa will also be talking about a relatively new work group on the social determinants of health. And so again, there are a lot of more people. These are just the co-leads, and we view this as a porous committee. All these subgroups are always reaching out into the center network and beyond for expertise to try to make data-driven decisions and recommendations to come back to you with, like we will today. Go to the next slide. Just to remind everybody, this is the famous JICA nuclear model. Thank you, Greg JICA, for this. The uniform data set continues to play a critical role nucleating a variety of other studies. So we know the UDS we're not designed across the Alzheimer's centers as an epidemiological study by any means, but we are providing an incredibly important platform which feeds into a variety of other studies, as well as the innovative research that occurs at each of the centers. And so this UDS, we're mindful of, is critical for enabling harmonization. Increasingly, it's necessary for increasing recruitment into these other trials. So the UDS is viewed as a way to provide a lot of the data and facilitate recruitment into things like DIAN, LEADS, the DLB Consortium, all FDD. and obviously feeds the large biomarker studies in genetics and MPD. Next slide, please. Just to remind people, what we're not doing today is talking about things that we've covered in the past. So for those of you who haven't had the opportunity to participate in many of the other sessions previously, we have previously reviewed the forums around clinical diagnosis and the revisions there, including adding more information to clarify dementia syndromes due to progressive supranuclear palsy, critical basal degeneration, vascular cognitive impairment. We've revised and updated the sections around biomarkers, given their growing importance, and keeping up to date the etiologic diagnosis and how that relates. Remind people we're bringing back the Parkinson's evaluation, the UPDRS, as a good way to harmonize, again, across the heterogeneity of disease. It becomes more and more important. And we're going to talk about behavioral neuropsychiatric symptoms today as well, as sort of another example of the importance of those for harmonizing across the spectrum of dementia syndromes. So we won't be talking about those, but all those are recorded and available if anybody wants to go back and look. On the next slide, this is then what we are going to be talking about today. And so we're going to have Kostas give us a discussion about the importance of neuropsychiatric symptoms in the new UDS and where we are in our considerations around that. Dr. Suzanne Schindler is going to talk about revisions that we will recommend around how to document people who have been exposed to AD disease-modifying therapies. Dr. Andy Saykin is going to talk about a very important effort to try to better define and operationalize how centers use the label subjective cognitive decline. Dr. Lisa Barnes is going to talk about social determinants of health. And then Dr. Carlos Cruchaga is going to talk about, again, COVID, this little thing that's happened while the UDSv4 got kicked off. So we have lots of things that our plate continues to grow to focus on. And then Dr. Sarah Biber, our NACC colleague, is going to tell us where we are and bringing these updates to the community back to you to actually implement and try. So with that, let me turn it over to Kostas. Thanks for joining this morning, Kostas.
Well, good morning, everyone. Thank you for inviting me to present, Allan. It's been great working with the team together to make some suggestions about the neuropsychiatric symptoms and how to approach them in UDSv4. Just to emphasize a couple points that Allan made, I'm presenting on behalf of a group that's been working together for a while. And what I'll be presenting is still very much in the proposal phase. And so we're looking forward to feedback and comments from all of you. Could I have the next slide, please? So I want to emphasize why we're taking this approach, mostly because we're all appreciating the importance of neuropsychiatric symptoms, especially in the early phases of cognitive disorders. And so we thought it was a good idea in UDSv4 to strengthen aspects of UDS around NPS. Our general goals are to capture NPS better in participants without dementia. One of the things that the science is teaching us that it's important to differentiate age of onset of these symptoms. We also want to strengthen how we do psychiatric diagnoses using the DSM-5 text modification that recently came out. In particular, to make sure that we're all on the same wavelength with differentiating symptoms, for example, dysphoria or depression from a syndrome, which might be a major depressive episode, from a disorder, which might be major depressive disorder. So streamlining the use of DSM in these concepts is an important goal that we're trying to achieve with these changes. And then finally, as you'll see in a moment, mob behavioral impairment is becoming more prominent as an important syndrome that we're hoping to have the Centers program help us better understand. So we want to build assessment of NBI into the broader UDS. Next slide, please. So I will quickly go through The background science, neuropsychiatric symptoms have been on our map for 20 years now as a field. We're appreciating that in people with dementia over time, they are universal. On the left, you see one of our Cache County reports, which lists the kinds of neuropsychiatric symptoms we're talking about, and they're accrual over time, so that in a population of people with dementia over time, close to 100% have developed one or more through the course of illness. And also this cardiovascular health study and other replications have suggested that in MCI, at least in the early phases of dementia, we have a frequency of various neuropsychiatric symptoms of the order of close to 50%. Next slide, please. Why are these important? This is just a reminder that, in fact, about half of people who go on to dementia, and this is a NACC analysis, half of the people, whether they go from normal just to MCI or from normal to MCI to dementia, or from normal straight to dementia, half of them have neuropsychiatric symptoms before the onset of a cognitive diagnosis. Again, emphasizing how important it is to start understanding these symptoms and what they mean before we have the cognitive diagnoses and throughout the cognitive diagnosis. Next slide, please. Evidence now has accrued pretty strongly that if you have people with NPS in CIND, MCI, or even in cognitively unimpaired people, their presence greatly accelerates transition from these milder disturbances or from unimpaired to the next phase of cognitive impairment, raising the question about why that might be the case and whether this allows us perhaps to target them as treatments, with treatments that might attenuate dementia risk. Next slide, please. A group put together by iStart many years ago came up with provisional diagnostic criteria for the construct of MBI. You have the reference here, you have the diagnostic criteria here, but conceptually, this is the emergence later in life of neuropsychiatric symptoms that are persistent and impactful beyond the ADL, IADL level, impactful on relationships, social functioning, work for patients where this is an issue. And so these criteria now have been used in a number of research studies, and we think are now ready to be incorporated into NACC. Next slide. So MBI in particular has been associated with faster conversion to dementia than MCI alone. The first report, next move, is from a study by Tarragano and his group in Argentina. Patients referred, a large number of patients referred to a memory disorder center, differentiated at baseline as folks with lifetime psychiatric disorders versus folks with MCI with or without MPS, and also meeting or not meeting MBI criteria. As you can see in the survival analysis, progression to dementia was fastest in people who met criteria for MBI, whether or not they also met criteria for MCI, and that folks with MCI plus MPS transitioned to dementia faster than the other groups. Notably, the folks with psychiatric conditions that had earlier life onset but were occurring in these referred participants did not progress to dementia at a faster rate than everybody else. So the differentiation of age of onset becomes important. This work has been replicated in at least 4 studies. Next move, please. Just giving you the highlights here and happy to get into more depth if you wish. Can you advance the slide, please? And so there's been 3 replications in large MCI cohorts. One is from the NACC, where individuals with MCI who had or did not have MBI were compared, and odds ratios for dementia progression with MBI in MCI were on the order of 2 to 8. And in a large cohort of individuals with subjective cognitive decline, the presence of MBI also was associated with an odds ratio of 8-fold risk of transition to MCI, or really to a CDR greater than 0.5. So clearly MBI seems to define a condition that carries a lot of risk for dementia, and again, making the point that we thought it'd be important to study it further. Next slide. So what do we do now in the UDS? Well, we capture symptoms on the NPI-Q and the GDS. We capture psychiatric disorders in general on the B9 form. And on the D1 form at the end, we evaluate their contribution of these psychiatric conditions to the cognitive disorder. And I will note that the way the D1 form is set up right now at the end is needs strengthening in relationship to DSM diagnoses, or what exactly the various diagnoses recorded there mean in the psychiatric sphere. Next slide, please. What we are proposing to do is two things. First, in terms of symptom capture, to continue with what we're doing now, but to make some small changes to the B9 form so that we have items capturing euphoria and substance use disorders that we think are increasingly important, especially for FTD. And also make available the mild behavioral impairment checklist as an optional symptom inventory for centers that would like to use it. Move the slides, please. And I'm just showing you now a screenshot of the MBIC. It looks very much like the NPI, and our goal is to make this available for centers that wish to use it optionally. Next slide. Our approach also proposes new questions on the D1 form. These will mostly occur at the beginning, which they will go along the form of, as part of the diagnosis, whether clinically significant NPS are present, differentiate the presence of symptoms, whether they are recurrence or persistence from symptoms that the person might have had in the past throughout their life, therefore specifying the age of onset, and then clarifying if they look like a DSM disorder or not, and if they do or do not meet MBI criteria. As part of a survey that's coming after this, you'll have more chance to see in greater detail what we are proposing to do here. And in the second half of the D1 form, next slide. Oh, okay, I thought I had another slide there. But at the end of the D1 form, we're planning to streamline the diagnoses so that the conditions that are etiologically thought to be related with a cognitive disorder are diagnosed appropriately within the context of DSM-5 criteria. So let me end there. There was a lot of information in just a few minutes. I believe we have 10 minutes for questions, and you see the names here of the people who contributed to our task force. So if it's okay with you, Allan, shall I open it up and start looking at questions in the, and I don't see.
Please do. I don't see any questions yet. There we go, our first one.
I don't see questions that are relevant to what I just said, but there is a question about when UDS will start. So are there any questions about what I just presented?
Rob Sweet asked a question in the chat. He wrote, great overview. I feel like there's little information about how similarly or different centers approach obtaining the various behavioral data we currently assess. What do we know about the process, and how are we thinking about this?
I can partly only answer it, Rob. I think, I don't think we know, but I think what we are hoping to do with these modifications is to streamline this. So, so that part of our goal, once we all agree on what the changes will be a set of training so that everybody's on the same wavelength about how we capture these neuropsychiatric data.
There's another question, Kostas.
Okay, I'm not sure I see.
It says the UDS3 section collecting lifetime smoking, drugs, and alcohol is poor and does not allow to clearly establish abuse or dependence, neither duration. Are there plans to improve the collection of data for these important risk factors?
Yeah, thank you for helping me find that. I think right now there are not plans to make it much better. We certainly can talk about what we could do. The one addition we're talking about in the B9 form is to have a substance use question, not so much about smoking, but really about drugs, prescription substances, and alcohol. But this would basically be an opportunity for the clinicians at each center to record whether the person has a substance use disorder or not, and what the substance is involved, and whether it meets criteria for a substance use disorder or whether it's simply heavy use. So Jeffrey Phillips, yeah.
Good.
Hugely helpful to have better characterization of early behavioral impairment. One feature that would be helpful for relating these features to imaging, et cetera, would be some dynamic range in these measures such that can be used for parametric analysis. Does this seem feasible or appropriate to the NBI phenotype? Not sure I understand what is meant by dynamic range here. Could you help me, Dr. Phillips?
One moment, I can call on Dr. Phillips to use the mic if you'd like.
It would help.
While you're calling on them, I'll just add that I know there are a lot of questions about timing when forms and the like will be available. So the NACC will be distributing the survey that Kostas mentioned next Monday. And then Sarah, at the end of the session today, will be talking about next steps, and I'll defer to her to for NACC to be able to help address potential timelines.
All right, Dr. Phillips, you've got the mic.
Sure, yeah, no, thanks so much for the presentation. And I guess my question just is meant to ask, you know, with the kind of assessments you're developing, would this result in kind of a perhaps like some kind of overall score with that's I guess can be like used on an interval scale, or like a kind of a ratio measurement, or is it more categorical? You know, if we're talking about like statistics, can this be used in parametric analyses, or would be more limited to kind of categorical analysis?
Yeah, I hear you. So the answer is yes. These are commonly used in parametric analyses. So the two uniform measures, the NPIQ, Neuropsychiatric Inventory Questionnaire, has 12 individual symptoms, and for each symptom, a severity is recorded. So you can use a symptom level severity in a parametric analysis. It's not an interval scale, it's an ordinal scale, but you certainly can do that. And then you can add things up as well, so you can get a total scale score. The GDS, which is the Geriatric Depression Scale, also can be used for that purpose. The optional MBIC is also set up from that point of view, and so that you could use any one of those three in parametric analyses. You could also use it categorically.
Great, thanks. Yeah, I mean, we're used to using the NPIQ and GDS scores in that fashion. So I guess, yeah, my question is more specific to the MBIC assessment.
Yes.
So.
Yeah. The MBIC.
Yeah. We have time for one quick question, and then if you could maybe help answer in the chat, other ones just written, and then so we can move on.
So let me take the first one. How will we determine a DSM diagnosis? I think it will be largely clinical judgment, but I think what we would like to do is provide you with the criteria that are commonly used, so that you have that resource available when you're making that call. And this is exactly where we want to differentiate symptom from syndrome to disorder. My sense is that a lot of people use an individual symptom, say depression, as evidence of a disorder. And I would want to encourage a little bit more thinking about what else goes into it beyond an individual symptom before you call it disorder. And I'll answer the other question that's in the chat in typing. Thanks, Allan.
Thanks so much, Kostas. Next up is Dr. Suzanne Schindler from WashU, who's going to talk about the revisions for to document AD-specific treatments.
Great, thanks very much. So as Allan mentioned, we've been working on developing a new form to identify participants who have received treatments that may modify ADRD biomarkers. As everyone knows, last year the FDA approved aducanumab for clinical use. Thus far, not very many patients have received aducanumab, and Medicare reimbursement has now been limited to clinical trials. However, there are a lot of drugs in clinical trials, 143 to be exact. And Hannah, can you advance the slide, please? Thanks. So this is showing a recent review on all the progress that's being made in drug development. And as you can see, there are quite a few different treatments that are being tested right now. Currently, recruiting trials will require over 50,000 participants, and some of these agents have major effects on ADRD biomarkers. And we know that some of our research participants that are in our observational studies are receiving these treatments. Next slide. So we would like to add a form to identify which of the participants in our studies are receiving these treatments. Right now, there's not a uniform mechanism to do this. And this is concerning because some of these drugs could confound our analyses, particularly our analyses of biomarkers. So the clinical task force has discussed the best way to do this. One obvious suggestion is to add this to the medication form. But after some discussion, we think that the medication form is not the optimal place to record this kind of information. The medication form records medications that a participant is taking at the time of a clinical assessment, but it can miss transient treatment. So for example, if a participant received aducanumab for 6 months, but it was in between study visits, this would not be recorded on the medication form. The medication form is also not designed to capture participation in clinical trials. And in clinical trials, of course, many times participants don't know whether they're receiving the active treatment or placebo. So it'd be difficult to know what to record on the medication form. Additionally, the medication form does not capture any effects that can be related to treatments like ARIA, and those could affect ADRD biomarkers. And then one logistical reason for having a completely new form rather than doing this with the medication form is that these treatments and trials are rapidly evolving. And if we had a separate form, we would have more flexibility to change the form as needed. Next slide. So in working on creating this form, the clinical task force considered minimizing the burden on participants and centers, which is very important, and also respecting contracts with pharmaceutical companies, aligning our recommendations with other constructs, and also flexibility. We drafted an initial form, and then this was revised by the entire clinical measures and diagnosis work group. We then elicited feedback on this form from all of you at all the centers. This was in April, and we have now incorporated some of the suggestions that were made into a revised draft of this form. Importantly, we have decided to limit the scope of this form so that the major goal is really to identify or flag participants who are taking these treatments with the idea that this could confound some of our analyses, particularly analyses on ADRD biomarkers. And we really are not trying to provide comprehensive data to analyze the effects of these drugs. We're going to leave that to the clinical trials themselves. Next slide. So we have drafted just 3 questions. Again, we want to minimize burden. Of course, the second question is multi-part, but the 3 questions are again designed to help us identify or flag individuals in our studies who are receiving these treatments that may affect ADRD biomarkers, and also just to provide some basic information on their exposure. So question 1 is, has the participant ever been enrolled in a clinical trial of a treatment expected to modify ADRD biomarkers or been prescribed a clinical treatment expected to modify ADRD biomarkers? Now, right now, for the vast majority of our patients or participants, the answer will be no, and the form will end. Next slide. However, if the participant has received one of these treatments, we will ask some basic information on their exposure. So item 2 is please provide information about the clinical treatments and or trials. And this provides information on the type of treatment, specific treatment if known, and can be shared, the start and end date, whether the treatment was provided as part of a clinical care and or a clinical trial, and if the participant knows which arm they were in, the active treatment or the placebo. Again, this is not intended to be comprehensive information to evaluate the treatment. This is basic information for us to determine whether the participants' data, particularly their biomarker data, may be confounded by this treatment. The last question is, has the participant ever experienced amyloid-related imaging abnormalities, edema, ARIA-E, amyloid-related imaging abnormalities, hemorrhage, ARIA-H, or other major adverse events associated with treatments expected to modify ADRD biomarkers? This information is being collected because it may be helpful to neuroimagers trying to interpret MRI findings. Again, this is not intended to be a detailed data set for the evaluation of adverse events. So we expect that this form will initially be optional, and the major use will be limited to identifying individuals who have received treatments that could confound our analyses. It is likely that this form will be revised often, especially if new drugs are approved. And if a larger proportion of our participants start taking AD-specific treatments, it may be appropriate to add a greater level of detail about information like drug dosing and adverse events. So I would like to thank the members of the Clinical Task Force Clinical Measures and Diagnosis Work Group, especially Greg Jica, Jeff Burns, Teresa Gomez-Isla, and Nina Silverberg. We now have time to discuss this new form, and I'm particularly interested in whether centers agree with limiting the scope right now to identifying individuals taking these treatments. And if you think the amount of information collected by this draft form is too much, too little, or just about right.
Thanks so much, Suzanne. There's one question in the Q&A box from Dr. Weintraub. Can you see that, or would you like me to read it?
Yeah, I can see that. So the question is, if the initial question includes both experimental trial and clinical use of AD meds, then wouldn't the latter be captured on the medications form already? So if the participant at the time of their clinical assessment was on, say, aducanumab, that would be recorded in the medication form. However, if the participant, say they took it for a few months and maybe they had ARIA or for some other reason stopped taking it, then they could have received the medication, but it would not be recorded on the medication form. So that's one reason why we wanted to have this separate form, just because our medication form is kind of a snapshot at the time of the clinical assessment, and it can miss things that happen between visits. And we think that if someone receives 6 or 9 months of aducanumab or potentially another drug like that in the future, that would be something we would want to know about. All right, so I see another question. Is the intention to collect retrospective data on patients who have had exposure to AD modifying drugs via clinical trials as well? Or should sites focus on current and future exposures only? So that's a good question. As it stands in the current form, this would include any participation in these clinical trials. In the instructions, we will try to define a little bit more carefully what we mean by these treatments likely to modify ADRD biomarkers. That could be broad, but actually I think we want to be a little bit more specific. Of course, some of these treatments have been around for a while. And so, yes, as written right now, this would collect data on anyone who ever received this treatment, even if it was, say, five years ago. And I think that would be important to note, especially given that some people in our studies are followed for a very long time. All right, there's another question. Can you address how you will harmonize demographics, et cetera, with NIA CROMs? I'm not quite sure how to answer that question.
I think that was directed to Kostas earlier, so maybe he can type in an answer for that.
Suzanne Hunt asks or notes, you would have to update that list of treatments that impact biomarkers each year. Yes, that's true. We expect that this area is going to be rapidly evolving. Again, that's one reason why we wanted to make this a new and separate form, because it may need to be changed every year, depending on what's happening in the field. In fact, we went through quite major revisions of this form just over the last year because the situation kept changing with aducanumab. So there was another question, will this information be available to clinical trials not being conducted through ADRCs? So in terms of this form, this will be part of the UDS as an optional form, and so that the information will be kept there. In terms of will it be available, I'm not sure if that's asking if someone's participating in a clinical trial outside of the ADRC. We are intending that regardless of where the participant is receiving the treatment, whether it's within a clinical trials unit at an ADRC, or say that they are going to an outside clinical trials center, we would want them to record that information or provide that information to us. Yes, Betsy Grant says that it seems like a form changing often will have some implications for data management. Yes, I think that's true.
Jeffrey Phillips had a question for you about whether neuromodulation or other forms of non-pharmacological interventions are also going to be captured.
So right now, we are not intending to capture that kind of information. Right now, we're trying to restrict the scope of this form so that it's really directed towards things that we expect will have a major impact on ADRD biomarkers. So drugs like aducanumab or other amyloid lowering therapies. And of course, there's a wide variety of other treatments. But the intention right now is to focus on those. It's possible that over time, we might want to add other types of interventions, including non-pharmacological interventions. But we wanted to keep the burden on centers and participants relatively low, at least for this initial version. And so we didn't want to expand the scope.
If I could remind people to please type your questions into the Q&A window rather than the chat window, because we're not able to monitor the chat window as readily. There is a question, Suzanne, from Dr. Paul Newhouse in the chat that says, I'm puzzled how sites will be able to answer the question as to whether treatment would affect AD biomarkers, as many non-amyloid or tau treatments can do so. I think you touched on that in your previous comment.
Yeah, I think that we will have to provide pretty detailed instructions on what we're referring to, and that list may change over time. It's true that there's quite a very large number of drugs that could potentially modify these, but really for this, again, we're trying to limit the scope to treatments that we know have a major impact on these biomarkers. For example, even some NSAIDs are thought to affect A beta levels, but that would be quite a task to deal with all of those. Really, we're interested in things that have a major impact, like anti-amyloid antibody, at least at this point. And of course, the medication form does capture a lot of information on some of these, especially repurposed treatments. Some of them are being examined for their effects on AD and AD biomarkers. But this is more about, we don't want to miss people who are getting some of these drugs that have a profound impact on ADRD biomarkers. So that's more what this form is about. All right. Do we have any other? Okay, looks like next up is Andy Saykin, and he's going to be talking to us about SCD.
Great, thank you, Suzanne. Off to a great start with this meeting, and appreciate the opportunity to talk with everyone today. So this is one area within the work of the cognitive subcommittee or working group of the CTF. And today we're going to address the topic of subjective cognitive decline. Next slide, please. Okay, so why is this important? Briefly, there's a rich history in this area that I'm sure most of you are familiar with. But there's been a lot of epidemiologic and clinical research looking at what we used to call them cognitive complaints, but we're told that's pejorative, so now they're concerns. But essentially, this is subjective or self-perceived evaluation of one's cognitive function. And whatever you call it, it's well established as an early risk factor for dementia and also for more subthreshold levels of cognitive decline. The other reasons, the cognitive concerns are a key element of the clinical syndrome for early prodrome, for AD and other types of dementia, and are also one of the hallmark features of mild cognitive impairment, using the Peterson framework, as well as a number of others. There's also a long history of looking at observers, whether informants, collaterals, co-participants, I think is our current favored term for this. But regardless, it's an individual who knows the person well and can also rate them on the same dimensions of their cognitive function. That's rather widely used in clinical and research assessment for dementia. The topic of subjective cognitive decline, which now has become the consensus way of defining this issue. I used to have a slide with about 40 different definitions of from age-associated memory impairment to many other terms, but the field has coalesced around SCD, and there is an international SCD Consortium that was established I think maybe 7 years ago, and it's now an Alzheimer's Association professional interest group as well. So there's a lot of work going on in this area, and a lot of different attempts to use quantitative assessment methodology to get a better characterization of what we used to just call clinical cognitive complaints. And it's done from both the self and informant based framework. Now, as we really are into the era of precision medicine using biomarkers, ATN, and the rest of the alphabet for other pathways, In the genomic area, where we increasingly have whole genome sequencing and transcriptomics and other information on participants in studies, it's really important to have a phenotype. In the end, to really interpret the data, we need a very well-defined phenotypic characterization. In general, there's a role for cognitive concerns in very early detection, in enrichment or targeting for clinical trials, some of which specifically target SCD, and in general for patient-reported outcomes from interventions of all sorts, as just discussed by Suzanne, and the questions that came in for the last talk, as well as other uses. Next slide, please. So obviously many reasons to look at this. On the other hand, as Allan started us out, we want to be very focused about this. And while many of us, and I'm as guilty of this as anyone, have asked very extensive sets of questions of individuals about their cognitive function, we want to be efficient. So the task that was laid out for us was basically to determine how should cognitive concerns be addressed or assessed in UDSv4. Should we use just one or a few screening questions? Should we use some quantitative scales, some hybrid or staged approach? Beyond that, should we actually have a grouping for individuals, a classification as SCD, which is not a clinical diagnosis, as you know, but is often used in research. If we do define a group as being classified as meeting criteria for SCD, what criteria should be adopted? So our process in looking at these issues was to review the literature, which is growing rapidly, to look at the existing ADRC survey data, which is somewhat incomplete in this area, but we looked at what was available and can refine that. And also thought about what was used in UDS2 and 3 previously, which was pretty minimal, but the presence of cognitive concerns were at least noted. We invited some presenters to join us, Laura Rabin from Brooklyn College and the Einstein Study of Aging, who's written a number of reviews and some large meta-analyses. Some are, I think, under review now, presented her data to us. Shannon Rissicher presented a number of biomarker and outcome analyses of several of the scales. We met with the ADNI working group that's examining parallel issues and spoke to a number of other people as well. We considered some of the widely used scales and approaches and thought about the context of the 2018 research framework that's biomarker driven, and also gave significant consideration to the issue of methods that would be applicable in diverse settings, where so far data has been limited, but there's some, and we considered that as well. Finally, the cost benefit factors in terms of really the time burden required for both participants and staff, and then the issue of standardization of some measures versus post hoc harmonization of some of the range of measures that are out there. Next slide, please. Very briefly and very selectively, this is a 2010 epidemiologic study from Frank Jessen and colleagues, who one of the co-founders of the Scd Consortium. And essentially, they asked one question in surveying a large European primary care setting. Do you feel like your memory is becoming worse? And then the answers were no, yes, but this does not worry me, or yes, this worries me. And you can see the Kaplan-Meier survival curves on the right side, but basically it's, not answering no, answering yes, but it doesn't concern me. And then the bottom line is basically individuals who say yes, and it worries me, essentially establishing the fact that concern or worry about one's cognitive changes is also predictive of outcome, in this case, progression to dementia. Next slide, please. A larger outcome study looking at individuals who met criteria from the consortium for SCD was published by Rosalind Sloot from the Netherlands using data from international SCD Consortium. What you can see in the bar graph to the right is in the orange bars, basically the increased frequency for dementia in those that met criteria in each age group for SCD. And you can see that from about age 60 to 90, there's clearly a separation where there's greater risk, as one might expect, for progression to dementia. And then other factors that you would also expect, greater age, lower mini mental status exam, APOE, a clinical versus community setting, all were additionally predictive. Next slide. And I just present this to contextualize SCD in the broader NIA Alzheimer's Association framework, where it's really detecting stage 2 versus 1 and 3. So stage 1, no objective or subjective changes. Stage 3, essentially MCI. But stage 2, there's subtle subjective or possibly subtle objective changes that don't meet criteria. The behavioral symptoms that Kostas spoke of earlier, but essentially it would give us better characterization of this early stage. Next slide. So what do we actually propose? 3 questions that would be added to the form and would be used in a standard fashion throughout all the ADRCs. So we would adopt the question originally from Geerlings, used in the Jessen study. Do you feel like your memory is becoming worse? And the choices are yes or no, yes, but this does not worry me, and or yes, this worries me. Then in addition, we adopted a 2-part question that's been used at Rush University from studies by Lisa Barnes and others. And that is, how often do you have trouble remembering things? And the coding is from never to very often on a 5-point scale. And then secondarily, compared to 10 years ago, how would you rate your memory? And it's coded from much better, little better, same, little worse, to much worse. And the Rush group has a quantitative cut point for that, which we could look at, but that's really a separate topic. But we thought these 3 scales, which obviously are targeting memory, would be a way to very quickly and efficiently capture some standardized questions without necessarily imposing a detailed scale. Next slide. However, there's a lot of interest in this area. Many centers are already administering scales for cognitive concerns, and we are recommending that centers adopt one of 2 scales, either the Everyday Cognition Scale developed by Sarah Farias, that has 39 items. It takes about 8 to 10 minutes, or the Cognitive Change Index, which was developed by our group. It has 20 items and takes about 4 to 5 minutes. Both have some short forms and expanded forms and alternation. For now, these are where most of the data have been collected, and we're considering alternatives and efficiencies, but basically proposing that centers that are interested adopt one of these. And a recent paper has demonstrated that these can be harmonized as well to yield a standardized score that would bridge across these with a crosswalk table as well. Next slide. So how are we doing here for time? I guess we're okay. The content for the ECOG is shown here, and I think many of you are quite familiar with this. It's available in a number of the publications that are cited. These are essentially the item pool. The framework for the ECOG is compared to 10 years ago. Has there been any change in? And then, there are memory items, language items. On the next slide shows also some visual spatial items and executive items. So they're basically, capture of several different domains. There's a good coverage of executive and also questions on visual, spatial, and perceptual abilities. So a little bit longer and a little bit more comprehensive than the CCI. Next slide. The Cognitive Change Index, or CCI, has 20 items. 12 of the items are episodic memory related. You can see them on the left. 5 items are executive function related, and 3 are language related. And the framework for the CCI is 5 years ago, as opposed to 10 years ago in the ECOG. It's a topic of research as to what the best time frame really is. It may turn out that it's somewhere between 1 and 3 years, but most of these instruments probably are picking up changes from baseline regardless. In any case, the CCI is a 5-year framework and focuses on episodic memory. In some studies, only the 12 episodic memory items were used. So both of these are widely available and again can be harmonized. Next slide. And once you have this information, then the issue is, should we actually define individuals as meeting criteria for SCD? We could use the guidance from the International SCD Consortium, Alzheimer's Association, PIA. Those groups have defined also an SCD plus with an enhanced risk. Basically, the criteria are down in the middle lower panel there. But essentially, it's older adults with established cognitive concerns, regardless of the specific instrument that's used. And some issues are the setting, like seeking medical assistance, persistence over time, confirmation by an observer, and so on. So the questions that are still under consideration: should we introduce a cutoff that would actually define this group, which would essentially take a slice out of what now falls under the cognitively unimpaired or cognitive normal group, which we know is also, this is a subgroup that's prevalent in our cognitive normal or control group, and it may be worth looking at these individuals who tend to be heterogeneous and warrant further study in terms of early detection issues and biomarkers. We could also leave this as a clinical determination, that it would be the best judgment of the clinician, taking into account all available information about subjective and observer related ratings. If we did provide cutoffs, it could be just based on the 3 questions, and then it would be applicable to all centers, or it could also incorporate the ECOG or CCI, which again can be crosswalked. So we're giving some thought to that and welcome your feedback. Should it be only subjective or include co-participant information as well? Clinically, it's obviously better to have more information, include all of it. There's a fair amount of work suggesting stage-specific relevance, that very early stages, subjective changes may be most informative, where later, as anosognosia and awareness diminish, then it may be much more important to have the observer, whether it's a family member, friend, or clinician, provide that information. We could leave this issue about cutoffs and definitions for future research as data is collected, or try to define it in at least a preliminary manner now. So we're giving thought to that and welcome your feedback. Next slide. And just want to thank, Lisa Barnes, who you'll hear from in a moment, but it's co-chair of the Cognitive Working Group, and also the other committee members listed here, and others who participated in many of these sessions working on the issues. Thank you, and I guess we're open for questions and discussion.
Yeah,
Thanks. That was great. We have a bunch of questions in the chat, in the Q&A for you. Starting, I'll read the first one as you're trying to find it. Maria Corona asked a couple of questions. Do you differentiate subjective cognitive decline from questionable cognitive impairment, QCI? And are any of these not captured by the cognitively impaired no MCI?
Yeah, those are good questions. I think these are not necessarily synonymous, but partially overlapping, and it will depend on the specific definitions and criteria that are applied for each one. And what this question suggests to me is that ultimately we should have some table that probably breaks out, differentiates the criteria used for all of these entities and shows how they relate to each other. And then I see Brett Naskin has a question. Given the range of clinical phenotypes recruited into ADRCs, was there consideration to using broader language and memory concerns for the three proposed screening questions? Yeah, that's a good point, Bretton. Certainly, and it's also one of the reasons that there's an advantage to incorporating the other scales that have much better coverage of other domains. We could add questions and did discuss this, for multiple domains, and part of the challenge there is just the time of having every center ask questions about other domains, and it's still it is a consideration, and I understand completely where your question's coming from. At the moment, we loaded this for memory, which is historically what's been done in the ADRCs. But certainly other domains could be tapped to a greater or lesser extent. Let's see. Then Kathleen Welsh-Bomer asks, wondering whether the CFI, previously called the MCFSI, was considered as an option. This is the one we use, and it's used in some secondary and primary prevention trials. That's one that I think the ADNI working group looking at this has been considering. We did not see it showing up in many of the ADRCs and didn't really consider it for that reason. I think we're going to do an updated survey. If it turns out a lot of centers are using that, we could certainly add it and potentially harmonize it. And I will say also, I mentioned very briefly the work that Laura Rabin and a large group of collaborators are doing. It's basically aggregating all of the different scales that look at this issue from international studies, both clinical and epidemiologic studies, and generating an item pool from all of them and using statistical item analysis to try to bridge across all of it. So there should be an item pool that would allow the construction of an optimized scale. It's just not something that is going to be ready immediately in time for UDSv4. But I think the future of this probably is a scale derived from data from thousands of individuals on a global scale that will probably have optimized measurement properties in terms of brevity and statistical signal detection and so forth. And it will incorporate data on all of the different scales that are out there. I imagine the CFI was in that data pool, which had like 22,000 subjects, I think. So this won't be the final word on ascertaining cognitive concerns. Ranjan Dwara asks, would information from the informant not be important to include, given the frequent denial of impairment among patients developing dementia and MCI? Couldn't agree more. And we recommend that, I may not have said this, but we recommend that both the self and informant versions of either the ECOG or CCI, or if it turns out to be another scale that has a self and informant version, that both would be administered, because I couldn't agree more. They're both very important, and as I mentioned, may have stage specific value as well.
Andy, we should probably move on.
Okay.
If you could.
I'll respond to some of the other questions in the email. Thanks very much.
Thank you, Andy. That was great. Keep the questions and comments coming. They're really helpful. So I'll turn it over now to Lisa.
Good morning. Oh, what is it, afternoon or morning? I think it's morning for me and for people on the West Coast. I am excited to present our recommendations for the social determinants of health I'll be presenting with my co-lead for the Social Determinants of Health Working Group, Megan Zuelsdorff from the University of Wisconsin, who's doing some really fabulous work there on her STRIDE study. We co-led a wonderful committee of experts in the areas of social determinants, representing a number of ADRCs across the country, working with different populations. You might remember that about a year ago, we presented our proposal to create a module of social determinant measures. And this is a culmination of our committee's work over the past 6 to 7 months. But we want your feedback, and we really request all kinds of questions and information that we should be thinking about. So can you advance the next slide? I am going to be very brief because I want to give Megan the opportunity to present our vetting process and the actual questions that we're proposing to include. But just to give you a very brief and broad overview, what are social determinants of health? They are the conditions in the environment where people are born, live, learn, work, play, and age, and the wider set of forces and systems that shape the conditions of daily life. Why are they important? We've known for some time from public health research that anywhere from 40% to about 80% of health can be directly or indirectly attributed to non-medical factors, what we call the social factors, which are represented in this Healthy People 2030 Social Determinants of Health framework. And we know there's a growing body of evidence that social determinants can also impact brain health. I don't have time to go over that evidence in 10 minutes, but you can find a webinar on the NACC website where we presented a lot of the supporting evidence over a year ago. Next slide. So in addition to the impact on brain outcomes, social determinants also play a key role in understanding health inequalities. Most people should be familiar with the NIH Health Disparities Research Framework shown here that was developed to guide research on health disparities, in which they laid out 4 domains of influence that can be measured across the life course. In our committee work, we were guided heavily by this framework to determine which domains we wanted to cover in our module, which I'll show you on the next slide. So in making our decision, we were, just like everyone else, constrained to some extent by time limits and the fact that we needed to keep the burden low for participants as well as center staff. So given these constraints and thinking about the broad research topics and innovative science being conducted across the ADRCs with cognition, biomarkers, imaging, and the fact that diagnosis, disease progression, and access or response to treatment may each be affected by the factors that I have listed on this slide, we chose to focus on 3 of the 4 domains from the NIA Health Disparities Research Framework. And that's environmental, sociocultural, and psychosocial. And you'll hear more about these in Megan's section. Next slide. Now, this proposal is for an optional module, but we hope every center will use it no matter what population you're working with. You'll see that our constructs have broad applicability and are meant to capture social experiences across a continuum. We know that some social factors can confer health benefits to some populations and cause harm in others. And we want to be as inclusive as possible and understand all the ways that social factors can affect the outcomes that we care about. In the UDS 2 and 3, we didn't really address social determinants at all, other than some brief demographic questions. And because of the growing recognition of how important these determinants are, particularly for brain health, we included some basic questions in the core UDS battery, which I'm showing on this slide. And we presented this already at prior meetings, and you've had a chance to provide feedback. So some of you may be thinking, we're already capturing everything we need with these questions. But I would argue that these are just single questions, really only scratching the surface of the issue. And we have an opportunity as a consortium to take a deeper dive with these issues and collect data on thousands of participants to advance our understanding of the ways in which determinants can affect dementia risk, diagnosis, and prevention. So now I want to turn it over to Megan to discuss our vetting process and what we're proposing to measure.
Thank you so much, Lisa. Yeah, so that was an excellent overview of the kind of background and significance that we're talking here. I will try to give you an overview of what our decision process looked like, and then, of course, what the ultimate results were. This really was a committee-driven process, as Lisa has mentioned. We had input not only from a diversity of ADRCs with their different populations, but also different field level expertise. We had clinicians from all kinds of specialties. We had neurobiologists, we had epidemiologists and public health researchers. There were a number of criteria that we started with as we kind of thought about which constructs we really wanted to narrow in and focus on, but we also returned to them as we eventually selected constructs and selected instrumentation and items to operationalize those constructs. Overall, as Lisa mentioned, we really wanted to be sure that we covered multiple levels of analysis, those domains that are upstream of the really rich biomedical data that are already included in the UDS. We also wanted to select constructs where we knew that there were really robust empirical associations already established with brain health and dementia risk, and or with dementia risk factors and diagnosis and care access. We also, although we were keeping an eye toward the increasingly inclusive ADRC cohorts, we know that the centers have been doing really excellent outreach work, but we wanted to ensure that we focused on constructs where there would already be a really nice distribution of the exposures that we're proposing, so that when it comes time for initial data analyses, there is variability in those data. We obviously focused on constructs where we could find validated instrumentation to draw items from. And finally, we know that, and I know everyone here knows, there are a lot of really innovative approaches and methods being developed for using geocoding, linking participant addresses to public data sets to really capture a lot of unique place-based social determinants of health, segregation, environmental pollution, neighborhood level disadvantage. That is going to be exploding. So we actually focused in on constructs where we were pretty sure that we really did need participant self-report, that we weren't going to be able to capture through those kind of methods. Next slide, please. So on to the constructs that we ultimately selected. Drawing from that really upstream environment level domain of analysis, we selected access to transportation. I think everyone here who works with older adults knows that access to transportation is something that really exerts strong influence over the lives of the participants in our study as they age, including sort of their access to resources, their access to activities that they enjoy participating in, their access to medical appointments, and so on. We tried to capture sort of nuances of this domain by drawing items from a validated transportation security index, focusing on ideas not only like anxiety about trips and how that might inform a decision to make a trip or not, but also about the extra time that is drawn away from other things, other activities of daily living, if participants are using a mode of transportation that's not as efficient as it could be. Next slide, please. Next slide. Thanks. So moving a little bit downstream into what we can call as the sociocultural level of analysis, or this is what the NIA framework refers to, we decided that we really needed to expand on financial security versus insecurity. That is, an area where there are a lot of different kind of nuances that capture different aspects of this sort of social determinant. And we drew from items both from, from big nationally representative studies, the MacArthur studies, the health and retirement study, to really try to capture those multiple sort of domains that may be more salient for some communities than others. So we selected items that ask about perceived satisfaction versus stress with a participant or their family's given financial situation. We selected items that capture objective difficulties paying monthly bills or paying for medications or food. We recommend an item that actually looks at perceived social status relative to other people in someone's community. And finally, we recommend asking about this very commonly used, quite powerful marker of childhood socioeconomic status, parental educational attainment. Next slide, please. For our third construct, we recommend focusing on social isolation and connectedness. We know that social isolation has been identified as a really important contributor, modifiable contributor to global dementia burden. And we know that its protective converse, social connectedness, not only shows robust associations with brain health and dementia risk, but also is a really important determinant of how people can modify brain healthy behaviors that we might recommend they modify. So we're recommending a social isolation scale that is validated and already in use by the Rush ADC and other centers. And we are also recommending a measure of social connectedness that captures both strong and weak social ties, particularly when paired with partnership data and so on that are already collected through demographics. Next slide, please. And finally, the fourth construct that we selected really expands on the general discrimination items that we are already asking about in the new UDSv4. We focus here on discrimination in medical settings, knowing that it has important sequelae for the health care that people are receiving and that they are seeking, and that they are ultimately able to follow. So we selected 5 items that capture not only perceptions of medical discrimination, but also what the implications of that discrimination were. Is someone delaying or canceling medical visits? Are they not following a treatment plan that they otherwise might be? Next slide, please. I will just really briefly end before the Q&A on some details that I know are important for everyone here. We have a couple of recommendations for the administration of this module. I can try to remember them. First, we recommend that it's self-administered rather than having a research specialist verbally administer it. There's a couple of different reasons for that we can go into. It's also, we recommend that a participant responds themselves. This isn't really intended for a proxy to fill out. And obviously that has implications for the cognitive status of those who can complete it. We do recommend that it's filled out by all participants at least one time, ideally as early in their ADC participation trajectory as possible, but obviously these exposures are time varying, and some centers may choose to have people repeatedly fill it out. And finally, just based on some family and friends who were kind enough to volunteer to give this module a try, we anticipate that it's about a 5-minute module. It certainly takes many people less. If someone has functional limitations or other things going on, it could take as long as 10, but I think that would be on the outside. And with that, I'm going to stop. I'm excited to see what kinds of questions people have.
Thank you so much, Lisa and Megan. Great presentation and a lot of great work by the committee. So if you could, again, please add your questions to the Q&A. Glenn Smith has one for you, Megan or Lisa. Can you see that, or would you like me to read it?
I can see it. Can you see it, Megan? Could the common fears in persons with MCI mild dementia about loss of access to driving confound how these questions are interpreted? Oh, great question, Glenn. I guess that's a possibility. I think the questions that we selected had not necessarily been used across different dementia statuses. Is that right, Megan? You got them from that huge database, right? Of cognitively normal people.
Right.
So yeah, so I don't think this question is addressed, but this is definitely something we should think about, because this fear could sort of bias how they answer those questions. And that's also why we wanted to make sure that they were self-administered, so that people would not feel that that pressure or fear in answering the questions. We'll take that back to the committee though, Glenn. Thank you. Will Affleck says social determinants of health responses are subject identifying and PHI. I'm not sure what you mean by that. How are they subject identifying? I don't know if he wants to come off to get the mic to explain. Hannah, can you give him mic privileges?
Yeah, Will has been given.
Okay, go ahead, Will.
Yeah, so if we get too much into the exact state of an individual, and we've already given their 3-digit zip code, as well as their income bracket and other perceptions, the more detailed we get, it becomes personal health information. We can literally identify, are there any 104-year-olds who have this income level who are here? And since we know their gender and we know other things, the correlation of these makes it not publicly accessible. It's a good question for a questionnaire, but we have to think about the implications with the total visit. Thank you.
Okay, great. Thank you for that comment. This is actually did not come up in our committee deliberations. I guess, we have that risk with a lot of data that we collect, genetics, imaging, and all kinds of things. So we'll definitely have to think about that. This was all meant to be, completely anonymous, of course, but something to consider. Thank you. We have, let's see, Amy, for initial visit participants who are already diagnosed with dementia, who should complete the module on their behalf? Yeah, great question. We don't think that people who are already diagnosed with dementia, that these can be used in that population. I know centers vary on how they approach these issues with people who have dementia, and we'll leave that a little bit to your judgment in the centers, but this module was really meant to be for people who don't have any cognitive impairment or dementia. So they can have MCI, but we really wanted it to be for the cognitively normal up to MCI participants. And again, we don't think that these questions should be given to the co-participant. So that's another reason to have people who don't have any cognitive impairment. Felicia Goldstein wants to know, did the committee consider asking about lifelong exposure to challenges as opposed to only in the past year?
Good question.
Yeah, that's a great question. We did, and we have that question about the perceived social status from childhood. So
we also have it for most of the other financial security or insecurity questions as well. We ask about past 12 months, but then we also ask, have you ever had this experience? We recognize that the life course exposure is so important.
Right. But again, we were, constrained by not wanting to put too much burden, because if we put everything in here that we want, nobody's going to do it. I mean, just, we know how things work around here. So we tried to keep it pretty low. Suzanne Hunt, in all situations where a co-participant could be present, form instructions should clearly explain how to handle the situation where a co-participant strongly disagrees with the participant's response, especially when the participant is cognitively impaired. Okay, so that's a comment. ADRCs probably handle this in different ways and can have a profound impact on the data. Okay, great. Thank you for that comment. I mean, all of these things we're definitely going to take back to the committee, because this is not a done deal. And we, it's really meant to give you chance to give feedback to us. So thank you for these comments. And then Marissa put in a recent published article looking at social determinants in CDR 0.5. So thank you for that. And actually it looks like one of the people from our committee is a co-author on that. So we'll definitely look at that. Thank you. Then Rob Sweet, we have found that self-administered forms often require valuable clinician time to correct filling errors. Have we piloted this form in actual participants to see how readily they might complete it? No, we have not. We used Megan's wonderful family who are not participants in the ADRCs, but this is definitely something that we would want to do before we roll it out to all the centers. So thank you for that suggestion. We'll probably get some participants from my center and maybe some other people from the clinical task force can volunteer to provide the form to their participants, and we'll be able to get back to you with a more realistic time frame for completion.
Thank you so much, Lisa and Megan. That's fantastic. Again, and to that latter point, I think we'll do this with all the new forms, revisions. We're asking for brave volunteers among the clinical task force members or others who want to bring it to a few of their participants just so we can identify any major hiccups. But thanks again. And why don't we move on then to keep on time to COVID. So it's something we haven't, hasn't left us omnipresent. Carlos, thanks for leading the effort around this.
Yeah, thanks very much. So yeah, I'm presenting in behalf of many people working on the COVID forms. The goal for this presentation is to tell you what data has been collected, what problems has been found so far, especially burden on the ADCs, but also just to transmit that there is very important information that needs to be collected and why. So if we go to the next slide, I think at this moment, everybody realized that COVID is one in a lifetime event that we are all living, and has been affected in the US more than 83 million people. 1 million people has died because of this. And as I will present later, there is a strong correlation or association between COVID and dementia. So it's something that we cannot ignore for this. There are two forms for the COVID. The first one was before we knew about post-COVID syndrome or long COVID. And also at that time, we didn't have vaccines, or we didn't know about recurrent infections and many other things. So that was very early on the COVID pandemic. So that forms that were not ideal and didn't include a lot of information that has been shown to be relevant. So clearly that needs to be redo to include additional information. So if we go to the next slide, the reason that why we need to collect COVID information is because people with dementia are more likely to be infected with COVID or died because of COVID infection. We also know that COVID may result in brain damage and increasing the risk for dementia, especially in African Americans and Hispanics, in minorities. We also know that there are genes that are overlapping between COVID infection and Alzheimer's disease. We also know that COVID infection is going to change the proteomic profile in plasma and CSF, so AD biomarkers are going to be changed. We know that also may affect the brain, so imaging biomarkers, imaging information is going to change as well. So we really need to connect all this information in order to do analysis in the ADC subjects. If not, we are going to have a very big batch effect due to COVID. So on the next couple of slides, there are additional information, just keep going please, about this overlap between COVID and AD. We know that ApoE affects risks for Alzheimer's. This is a stronger risk factor for Alzheimer's. It affects COVID infections and severity. We also know that BING1 and other AD gene affect COVID mortality. And in the next one, the next slide, there are also more examples that are every day are being published between this genetic overlap and Alzheimer's. But we also know, as I mentioned, that COVID affects the proteomic profile. So all the proteomic data, or just NFL, A beta tau, all of those markers are going to change just because of COVID infection. So let's move to the next one. So As I mentioned, there is already a form for COVID and has been already filled almost 4,000 times from 17 centers and around 200 participants in each center. And there are people that has been already filled the form more than one time. I mean, that's great that this form is being used. At the same time, we need to realize that this doesn't cover the entire NACC population, is only 23%. But we also realize that the visits has been paused because of COVID. So clearly, I think that the forms are being collected. There are many people being missing, but some of these are ongoing. Move to the next one, and this is a very nice example. The top plot is the cumulative cases of COVID. As you can see, is keep growing up and is still growing. The Omicron wave is the one that you can see going up from January 7 of 22, and that is around 36% of the US cases. The plot on the bottom is the cumulative frequency of COVID forms filled by the ADCs, and it has been growing very nicely, but it has basically paused from December of last December. Only 5 forms has been submitted from Jan to March. And we know that the Omicron wave has affected a lot of people. We know all of us people that have had COVID in the last 6 months. So clearly that's something we can no pause. In any case, what we have learned about the COVID forms so far. So next slide, please. We know that around 10% of the participants may have COVID, but they have so that are COVID positive. 50% has been tested, but only around 3.6% have a positive test. Very few people has been hospitalized in this population, which is good, but also there is a large number of individuals that have indicate there are changes in cognition and memory before the COVID. So that is important and is a good reflection of the importance of getting this information. Let's go to the next slide. So in any case, I think it's clear that at this moment, these NACC forms have not really captured the pandemic because we have not been able to obtain data for every participant. As I mentioned, only 23% of the participants at this moment, and not that much information from the Omicron wave that a lot of people get infected. There are also, a small number of individuals that there are a positive infection at this moment, and very few individuals that have and need to hospitalize or go to the ICU. So clearly, a lot of individuals are having infected with COVID, but they have not tested, and we expect this around 3 to 1. In any case, as I mentioned, there are new cognitive and behavioral symptoms that can or cannot be independent of COVID infection. We don't know that, but we need the data. I think that's important. We really need the data to ask those questions. It's clear that capturing this information is challenging because the COVID infections in most of the cases last 1 week and then just people forget. Also, these infections are not synchronized with the visits. So it's difficult to ask people about when did you get COVID, what days, how long the last, and so on. And this is changing every day, right? We have now a different wave of COVID and a lot of people is getting infected in the last 2 weeks. But this is important information that needs to be captured. So let's move to the next slide. So I hope that you all agree with me that COVID has a big impact in the clinical and in biological aging. More and more studies are clearly describing the long COVID and brain fog, cognitive decline. There are changes in proteomic levels in plasma and CSF. Some of those proteins that change are some of the proteins that are used as biomarkers like NFL, or even APP or Ibera. So this is going to have an impact in the research that is going on the ADCs, similar to what Suzanne said with the clinical trials. This can have an important effect on AD phenotypes. So there was a new forms that many people has been working on that included more information, and yes, there is more burden in the participants. The goal of that new form was to capture additional information that was important for any potential future research. We spend a lot of time in use validated instruments. We read a lot of forms, a lot of those from the World Health Organizations, in order to have these validate instruments. We try to minimize the burden, and there is no difference in length for the people that has not been infected or had vaccine complications. And at this, when we were preparing this, 95% of the NACC participants were not infected, but I expect that a lot of the participants will be infected in the next time. So let's move to the next one. What information we are trying to collect in this form? History of infections, and we know that there are many people that are having breakout infections. The overall symptoms length, that's important, and first and most recent experience. So we are not trying to get all of them, people are having more than 2, but we are trying to get the first and the last one. We are trying to get history of vaccination and treatment if they need to have treatment. That's going to be a very rare cases, but vaccination, most of the people hopefully will be vaccinated. And we try to validate additional question about stress related with COVID and coping. The F3 form, which is for the co-participant, didn't change. And we eliminate some questions, or we didn't want to include some questions that are already captured in the NACC form. So everything related with cognitive, behavioral, and symptoms was not included. But this form is designed to work with that. If we want to study either where changes in cognitive or behavior phenotypes, when COVID infection happened, that is all there. We will have dates to do those analyses. So 45% of the ADCs has been or are currently using this form. 1/4 have paused and 1/4 didn't use it. The main reason for this is burden, burden in the participant and burden in the staff. And obviously the reason of discussing this forum here today is to try to get additional feedback from all of you and see what is the best way to make this a better form for everybody to use. Let's move to the next one. At the same time, I think there is a willingness from all the sites to use the form. I see 73% will be willing to obtain COVID information. But most of the ADCs don't want to make it a required. Hopefully not because they don't think COVID is important, but because of the burden. So if we can decrease the burden or help to obtain this information, hopefully we can change these numbers and obtain COVID phenotypes for all the participants. We can streamline even further the forms. There are some information that when the form was created, we thought was important, but maybe it's not, especially those related with relative common effect size from the vaccine, like sore arms or fever or something like that. Those can be removed. The form will be easier to fill, and I don't think we are going to lose any important information related with COVID. It's important to mention that these forms are also in Redcap and can be deployed in an iPad in the waiting room. They can also be sent to the participants the day before or day after the visit, and they can fill electronically. So for this, there are potential ways to decrease the amount of things that needs to be happening in the visit. It still needs to be done. So, but I think it's, as I mentioned, it's said like multiple times already. COVID infection affects plasma and CSF protein levels, it's going to affect brain imaging phenotype, it's going to affect cognitions. And I think that if we miss this information, all the downstream analyses that are ongoing in all the ADCs can be affected because of COVID. I don't think I have any more slides. Can go to the next one. Yeah, so I am just to say thank you for all of you, and also there are many people that has been involved in this forum, especially Jace Nobel. I couldn't make it today, but also people from NACC and many other people. So so yes, representing the group here.
Thank you so much, Carlos. We have just a few minutes for questions. I don't see anything in the Q&A box yet. There we go. Our first one is there. Can you see that, Carlos?
Yeah, so that's a question that we have had multiple times based on what we know about COVID. These times that people can have pre-infection, the idea will be to have this for every visit, because it doesn't need to be yearly, but I think that every visit, I know that different ADCs has different, the participants come in at different intervals, but the idea will be to do every visit.
I have a quick question for you, Carlos. You've done such great work with SomaLogic and the profiling in plasma. Do you have a sense for how broad the protein changes are in the plasma proteome as a result of infection?
Yeah, so we are working in a manuscript for that. So we did a study that was not Alzheimer's disease related, that was only COVID, and we did SomaLogic, so proteomic profile, 7,000 proteins. In people that have COVID and they need ventilation or death. And we found a lot of proteins that change. And for those proteins, we did a pathway analysis. And the top two pathways was cardiovascular. And the second one was Alzheimer's. Oh, wow. And that was not an Alzheimer's study. I do a lot of Alzheimer's, but that one was not Alzheimer's. So NFL changed, Tau changed, APP change. So I think I was quite surprised that we found Alzheimer's. And as I mentioned, that was not Alzheimer's, this project at all. So it has a lot of impact.
And I'm glad you mentioned that. That's huge incentive for everybody to really strongly consider using the new forms and the updated forms and try to do that consistently. Thank you for that work.
Okay, thanks.
So we will transition now to Sarah Biber and Laura McLeod to bring us up to date with next steps.
Great. Thank you, Allan. Hello, everyone. My name is Sarah Biber, and I'm the program director at NACC. I am thrilled to be here today with my colleague, Laura McLeod, who is our talented senior Redcap developer at NACC. So we'll be teaming up for the last part of the seminar today to update you on some of the systems that we're modernizing at NACC and how this will bolster UDSv4. We have some other members of the NACC team here today as well, including our director, Bud Kukul, our deputy director, Carrie Stevens, our research team lead, Melissa Lurch, and our special project manager, Hannah Rosenstrader, as well as some others. I want to just give a huge thanks to Melissa, Laura, Hannah, and some other folks at NACC for helping to pull the seminar together in collaboration with the CTF today. Okay, next slide. So as you're hearing about today, we're in the midst of this huge content update. The last one happened in 2015, and a lot has changed since then. So these UDS updates are critical for advancing the field. We're really honored to have the opportunity to collaborate closely with the CTF in this effort. And this time around, the UDS update is really more than just a content update. It's going to be different because it's going to be accompanied by a lot of other big changes at NACC, all of which are aimed at modernizing our systems and really better serving all of you, the ADRC community. So today, Laura and I are going to give you a preview of some of the modern UDS related tools and resources that we're developing in collaboration with others in the community. This includes a new electronic submission system, new pipeline and database that's going to be designed to accommodate additional data integrations, as well as a new search and access interface. Next slide. So the existing submission system at NACC is 20 years old and in need of an update. We want to make it easier for all of you ADRCs to submit data. So this is going to involve putting a modern submission system in place that is cloud friendly and virtualized. In addition to enabling electronic data capture, NACC will continue to host regular batch submissions for the sites using UDSv4. We are starting with Redcap because this is, for one, the canonical tool for forms data capture. In addition, we did a survey and 29 centers have shared that they're either already using Redcap or interested in using it for UDS. Next slide. So we're eager to co-develop an electronic data capture system in collaboration with the ADRC community. We really want to ensure this effectively serves the community's needs. We don't want to build it and hope that all of you come. So we are collaborating extremely closely with the community to put an effective electronic data capture system in place. So NACC, together with the Data Core Steering Committee, launched the Electronic Data Capture Workgroup last January. We are currently collaborating with 60 people across 20 ADRCs to co-develop Redcap forms, define requirements, develop training and education materials. I want to, next slide, please, Hannah. And in the future, all UDS data will go through Redcap at NACC through one of these mechanisms. And that includes the direct data entry into Redcap, synchronizing local ADRC Redcap instances through Redcap APIs, but we will continue to host bulk upload of CSV files into NACC Redcap. Next slide. I want to thank all of the Redcap workgroup members who've been contributing to this effort, including my co-lead Sudeshna Das, as well as the co-leads for each of the subgroups, which includes Carrie Stevens, Ben Keller, and Laura McLeod from the NACC team. Next slide, please. Oh, sorry, can you go back one? And I want to mention too, there's a link that's been shared in the chat a couple of times that will take you to a web landing page where you can sign up for this group. It's not too late to join. We welcome more input, collaboration with the community. So if you're interested in being involved, please reach out to us through this form. Next slide. Okay, I'm going to pass off to Laura.
Thanks so much. So for some background, Redcap is a powerful web-based data collection software program that was developed by Vanderbilt University in 2004. Since then, it has been licensed to almost 6,000 institutions and is currently used by over 2 million people across 145 countries. And it can be used for both research and operations. Next slide, please. So as Sarah mentioned, we polled all 37 ADRCs about their data management processes, including data collection and submission to NACC. And what we learned from them is that there are several things that they'd like to see in regards to UDSv4 data collection and NACC submission. So all of the items on their wish list are listed here, and there are ones that are available in or can be accomplished with Redcap. We know that several ADRCs are interested in direct data entry into an EDC, either on a computer or a tablet, and some are additionally interested in participants entering data themselves via survey. This will be available to all ADRCs via the Ready to Launch project that our EDC development subgroup will build for you. Some ADRCs are interested in the ability to submit data via API, and that will be possible when using Redcap. In Redcap, quality checks can be made at several points on a question-by-question basis in the form of branching or skip logic and by field validation. Those quality checks happen in real time. On a form level, data quality rules can be run in real time or after data entry. Data quality rules, which can be customized, can also be run across multiple forms. There are several export options in Redcap, including R and Excel, both of which are important to ADRCs. And finally, most centers indicated an interest in receiving training on how to use Redcap. Our EDC documentation and training subgroup, of which I am a co-lead, will provide training materials such as SOPs to get you started and supported along the way. Next slide, please. All this to say that you will experience reduction in staff burden and higher quality data by using Redcap for data collection and submission. In terms of data quality improvement, it will be very clear to staff and participants which questions are to be asked and which forms are to be completed. There will also be fidelity checks across forms so that data entered into one form can be carried over to another when applicable. In terms of streamlining workflow, built into Redcap are some modules that you can use to flag any discrepancies and address them. This is in addition to the data quality checks that can be run. By using those features, you will experience fewer errors upon submitting to NACC, which obviously will save you time. And remember, the development subgroup is building this project for you, so you will have a turnkey solution. You won't have to do any of the design yourself. And as I mentioned, we will provide you with the training tools you need to get your staff up and running. And with that, I'll hand it back over to Sarah.
Thanks so much, Laura. Next slide. So I want to circle back to some of the other related modernization steps that we're taking at NACC. So a lot is changing with the center's program, and we are working to put a modern database in place to support these changes that are aligned with NIH's overall data science strategy. So NACC is actively working to build a new pipeline and database that will not only accommodate UDSv4, but also effectively scale to collect and integrate new data streams over the course of our current award cycle and really provide a robust long-term resource for the community. Next slide. So we are going to be continuing, of course, to collect all of the data that we have traditionally collected, including the longitudinal clinical data, neuropathologic data, legacy MRI PET data. In addition, we'll be adding some new data streams collected at NACC, including digital biomarker data, digital neuropathology data, as well as EHR and CMS data. We also really want to expand the amount of metadata that we integrate from partners like SCAN, NCCRAD, and NIGADs, and connect this data to NACC IDs for all ADRC participants, so that can be easily searched by investigators. Next slide, please. So once again, we're calling this, we don't want to do this in a vacuum. We don't want to build it and hope that you come. For this data front door solution that we are currently defining requirements for, we want it to be a resource that is really responsive to the community's needs and will advance the field. Our ultimate goal is that this will be the one-stop shop for all ADRC data that'll be easy to use, self-service, cohort discovery enabled, real-time, and integrated. We are eager for input on the requirements for this. We want to understand your needs, your pain points, how you want to see things connected. This is launched as a pilot project to define these requirements. We're working in collaboration with NCCRAD and NIGADs on this, and we would absolutely love your input. We are looking for members of the community, researchers, clinicians from across this group at the ADRCs and also beyond who want to give input on this. And so we welcome you to sign up to join one of our focus groups. That's a 1-hour commitment. We also have a survey that we'd love to get input on from folks here as we work to build out the requirements for what we hope will be a very valuable tool for the community. Next slide. And our real hope with this data front door is that having all these different data streams connected by NACC IDs and searchable through this single data front door is going to enable researchers really to ask some really big new questions in Alzheimer's disease and provide a large set of integrated and heterogeneous data to be able to answer them with. So this last slide is just summing up once again, this is a collaboration. We are collaborating with the CTF on this content. You've heard all these wonderful talks on today. We are collaborating with our electronic data capture work group to develop a streamlined submission system. We're exploring collaborations with several partners right now to develop an integrated pipeline and database, as well as currently have collaborations going with NCCRAD and NIGADs to define the requirements for our new search interface, this data front door. and hopefully collaborating with you too. We love your input. So keep an eye out for the links that have been shared to our feedback forms, and look forward to hearing your thoughts through that mechanism or by having you join one of our focus groups. So when is this all going to happen? When is this all going to be available? I have a feeling that may be a question that some of you have. So there are some components of this that we are still working to develop in collaboration with the CTF. The content pieces of this, we're still working to define the architecture, the design that we want to design and build for some of these components. But we are committed to keeping you in the loop. We're going to be providing regular progress updates to the ADRC community. We are transparently tracking all of the steps of this in collaboration with the CTF, as well as with our electronic data capture work group. We are going to be providing email updates. Well, actually, you should get one from us in the next 2 weeks on all of this, as well as newsletters. And we're actually going to have a webpage on our website that's going to be dedicated to updates on UDSv4. So we'd also love to get your input on other ways you might want to receive updates, or which ways of series updates are going to be most beneficial in your mind. So please also get another feedback form, but please provide some input to us on that as well. And once again, all of these surveys are accessible through the link that has been shared in the chat several times. Okay, I'll close with that. And thank you very much.
Fantastic. Thanks, Sarah and Laura. NACC has been just a phenomenal partner. So thank you for all the heavy lifting that you guys do. And we have time for just 1 or 2 closing questions. Sarah, if you can see in the Q&A, I'll let you and Laura answer.
Let me take a look here.
I could read them as well.
Oh, here we go. Yeah, I see. So I see here, can you expand on the EHR CMS data collection, please? I'd be happy to. I'd also be happy to call on Carrie Stevens, who's actually leading a supplement pilot project in collaboration with 3 ADRCs on this right now to develop this pipeline. I don't know, Carrie, if you're available to hop on. If not, I can answer.
Yeah, I can jump on, Sarah. Thanks.
Thanks.
And Carolyn, we actually met recently to talk about this as well. So I'm sure you're remembering that conversation. And it's a great question for the broader audience. So NACC has a COVID supplement, administrative supplement that we're working on in partnership with Washington University, Columbia University, and Indiana University ADRCs to basically develop pilot development of infrastructure with those 3 ADRCs for electronic health record data capture, the new modified COVID form that Carlos just gave you a great overview of, and development of a pipeline to be able to access a secure enclave that NIA has been sponsoring, where we can analytically use Medicare data at will in combination with NACC data through a secure enclave that the MedRec company provides. So that supplement is scheduled to persist through May 2023. And our hope is to have a demonstration pilot by next spring that shows the ability to combine UDS data, NIGAD's genomics data, electronic health record data, new COVID form data, and Medicare data all in one across these 3 ADRCs. So I want to thank very much our 3 ADRC partners who have been just tremendous in really working through how we approach this, how we think ethically about how we talk to participants about collecting these extra data in a way that works for everybody, in addition to really complex governance. That's all in the works right now. Sarah, if you want to add anything, feel free. Yeah.
That's wonderful. And I see that there's a question here on translations from Monica.
Sarah, I think, if I could make that the last question, and then we'll try to answer in the chat and wrap up since we're at time.
Okay, gotcha. Yep. Sorry, Allan, did you want to close with?
Yeah, I was going to let you answer that last one.
Oh, that last question. Yeah. So plans in the future for to translate, adapt to Spanish. So we have plans to adapt the forms to both Spanish and Chinese. We are have established some partnerships with two different ADRCs actually on this, and are in the process of developing some proposals for how that work will be done. But those are the two languages based on, we did a survey of all the ADRCs, you all responded, and those were, those two languages were the ones that emerged as kind of having the biggest needs. So that's what we're going to be focusing on at the onset.
Thanks so much. I want to again thank all of the committees that have been doing all the heavy lifting and the great presentations today. We really want your feedback to continue, so thank you in advance for continuing to work with us so that we can do the best job possible. And I want to thank the NACC team and NIA teams again for their support and collaboration in this process. And thank the nearly 300 of you out in the audience that have been participating today. Clearly a lot of interest, and so we appreciate it. With that, I think we'll sign off. So thanks, everybody. Have a great weekend.
Yes, thank you all. And I do want to reiterate too, so that you all can share with your colleagues or friends, we will be posting this webinar to the NACC YouTube channel. It's pretty easy to find if you just type in National Alzheimer's Coordinating Center there. You can subscribe to be notified of any webinars that we post on our channel, but we also will be sending out an announcement to everyone when that link is live. So thank you again for attending. Thank you so much to all of our collaborators from CTF for putting this on today. It's been a great update. Thank you.